for the,
Okay.
them to go live and they'll. Oh, Ryan's on.
Hi, I'm here. Hello.
And we should be good.
Okay, I'd like to call the Health and Human Services Committee meeting to order if I could. I entertain a motion to approve the May 10th minutes.
Second, Foley.
Okay, great. All in favor?
Aye.
All right, you'll see we have two appointments tonight. One to the Community Services Board. Monica Selvage was recommended to serve on the board at the last Community Services Board meeting. And Sarah Dawson for the Alcohol and Substance Abuse Subcommittee. Amanda did tell me, bring to your attention that both of these terms are 6/1/21 to 10/31/24. So if, without any objection, I entertain a motion to make those two appointments, one to Community Services Board and one to Alcohol and Substance. Okay? All in favor?
Aye.
All right. Kathleen Cuddy has no resolutions tonight, and she's not going to be here. She has a conflict tonight, but she did give me just a couple of things to update the committee on. In terms of COVID-19, the second round and final shots are happening in every school district in the county this week for COVID vaccination. And Health Department is doing that in partnership with East Hill Family Medical and the city. There's outreach happening, kind of pop-up clinics at smaller venues that are going on as well. Those are pretty labor intensive, but they're really trying to reach out to places where they can improve access and improve the vaccination rates if possible. Testing is being performed ongoing by EMO at the CCC site. And I think a little bit of frustration, the health department is receiving the same information as everyone else from the governor's office in terms of updates and changes. So basically she knows what the general public knows in terms of the state message. She did want me to bring to the attention, I think Lynn Marinelli, our budget director, had sent some information as well. The health department has done an excellent job claiming various sources of revenue to cover all the grants they have, the state and federal funding to cover the 2020 COVID expenses. So that will only benefit the county in terms of making sure we're maximizing those kinds of revenue. She will next month bring the ELC grant and discussion to this committee. I did find out that that is the epidemiology and lab capacity grant. And from what I understand, and we'll have more information, it is going to really be a school-focused money coming to the health department throughout to the schools. And it's going to be for surveillance and testing, especially in September when things open back up. I think there's a goal to keep close eye on any potential outbreaks and minimize those kind of things. So she'll give us more information about that. Like I said, I don't know how much their school is interested. I don't know what the dollar amount is, but we'll get more next month. CAB education has begun, and the health department environmental division is working with children's camps to open up both and meet the requirements of certifying those camps. And next month she will also come to committee and give us an update on the WIC office move. So those are the highlights from some of the information she has on her report and some of the things she wanted shared with the committee. So you'll see tonight, we do have 10 resolutions, 4 resolutions for the Office for Aging, 3 for DSS, and 3 for mental health. I'll start with Brenda, if I could. She has given us some information in terms of, we're still waiting for the cost estimates for the build out at the Boyle Center. We've met with them months ago, and I think that's still in process. She also has included here the 5 senior citizens that we didn't have the May luncheon for. There'll be some recognition in a newsletter and maybe a small event in August to recognize those 5 senior citizens. And she continues to work with the health department to increase availability of vaccines for homebound individuals. There was a webinar, I think, that Brenda included me in. There is a real targeted outreach to try to identify with those that are essentially homebound and find mechanisms to get into their houses, whether it's working under contract, working with certified home health agencies, but that is, appears to be the next level of push. And if Brenda's on, if she wants to add anything additional before we get into her 4 resolutions, by all means, go ahead.
Thanks, Elaine. I appreciate you bringing that up, the continued work we have been doing all through the pandemic, and then now, fortunately involved with the efforts to immunize the seniors. That's been a real priority in 2021. And then we just continue as an office to really respond to the needs of the seniors in terms of programs and servicing that has increased throughout all this. And continue to be directed through New York State Office for the Aging in terms of funding and expectations regarding those different services that we're really seeing an increased need for at this point.
Okay, any questions for Brenda before she gets into her resolutions? All right, great. If you wanna, the authorization and acceptance of the CARES funding. I guess it's money coming through that could be used through 9/24.
Yes. Yeah, huge amount of money that's coming in. It's actually it's under the CARES Act, but they have given it to us through our particular lines of programming that we already do. So they've designated it in 4 different areas, over 100,000 for supportive services. And that's kind of a broad category where we can do a number of different things. We can provide in-home services. We can provide in-home some equipment and aids. It helps with transportation. It helps with activity programming. We helps with the social isolation, dealing with that issue. We got 34,000 for caregiver services. So caregivers have really been very, very stressed throughout this pandemic, so we can offer them a little bit more. We received 165,000, a little over, to increase our meal program. We've had a huge increase in the number of people participating in the meal program, as I've been reporting throughout the last several meetings. And then also a little over 10,000 towards disease prevention. It's been a really rough year for folks with chronic health diseases because they've often been afraid to utilize their doctor and physician services and go out and get what they need. So there's an increased emphasis on programming to help get them back up to a healthier lifestyle. Totals 311,682,000 coming. And this is in addition to the over 200,000 that we have already gotten in the last about 10 months. So a lot of money that has come in to help us continue to serve or increase our services to the seniors.
As we talked about, this is money that can be used through 9/2024. So anything you don't use this year will roll over into next year. Is that how it's going to work?
Absolutely. It's got some nice flexibility there that we can use it through that time period, September of 24.
Can I get a motion for HH1? Okay. Any further questions? Trish?
I just have a question. Hi, Brenda.
Hey.
This is Trish. In the department expense line items, you had one for 100,000 and another for 63,000. And I was just curious, it doesn't look, is that staffing? Because there's a separate line for staffing. What are those?
So that is done that way because of the concept of being able to roll this money over into future years. It gives us the flexibility to include it in staffing, include it in programming, including it in supplies, whatever we really need to do with it. It's hard to predict getting this much money all at once, exactly how we're going to utilize it. And this gives us some flexibility to move in the directions that we need to and be responsive to the needs.
Thanks.
I need a vote for HH1. All in favor? All right. Any opposed?
Aye.
All right, great. Okay, Brenda, HH2, Office for the Aging, to create and fill a full-time aging services specialist.
So as a result of all that funding that we're getting and the increased expectations for our department and the increased numbers that we're serving, we are asking to be able to use some of that money coming in, as Trish noticed, that we are allocating some of that funding to add one full-time staff person to the department. It's gotten to the point where we just can't, the staff are at their maximum capacity, and with all this extra funding, we really need at least one additional person to help us fulfill the requirements of this funding. We know, again, this funding is expected through 2024. Certainly if the funding was to disappear at some point or not remain at this level, we would be able to abolish that position if we needed to in the future. But feeling pretty confident at this point that we've got, quite a bit of time to work through this money and provide these services with that additional person.
Great. Can we get a vote for HH2? Okay, we're all done with that. All in favor?
Aye.
All right. Any opposed? All set, Ryan? Tim?
Yes. Good. Aye.
All right, thank
Wow.
you. HH3, create and fill a full-time aging services assistant, and you see by the title of the resolution, it's abolishing a senior typist position that is vacant and replacing it with the one full-time aging services assistant position. So I get a motion. Would you want to say anything more about that, Brenda?
No, it's really kind of along the same lines, and it's pretty self-explanatory, I think. Unless anybody has questions.
I get a motion.
A motion, Foley.
Second, Strong.
Thank you. Any questions on this?
Madam Chair, can you hear me?
Yeah.
Hello?
Yes, we can hear you. Can you hear us?
Yeah, I just wanted to see whether you could hear me. Thank you.
Okay. Okay, we can hear you, Tim.
Thank you.
All right.
I'm just curious about the grade and pay. Is
Okay,
it lateral?
it is not, I think would be an upgrade in the title. Is that correct, Brenda?
That's correct.
14 and one's something else?
So, 17.
I would assume whoever, potentially the person who left, it was on step 4.
Yes. Right. So it ended up being, plus we've taken back a couple of really small contracts that total about $10,000 that we're now doing in-house. So between that and the step 4 versus the starting salary, we're easily able to cover that increased grade. And one of the things I like about that is that in our department now, we will have 3 people at that grade 17. I'm sorry, grade 14, not 7. I think it's not in there. Anyway, we've got 3 people at the same grade, which I think is kind of nice. It makes when we're working as a team on things, it just kind of helps us. Everybody's working together to do what needs to be done, and just works really well.
And this is more versatile in your opinion, in terms of what you can assign?
That's exactly really what I was saying. Absolutely. Yep.
Okay,
Mhm.
can we get a vote on this?
Aye.
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 Tim and Ryan, all set?
Yes, Madam Chair.
Yep.
Aye.
All right, great. Then lastly, Brenda, HH4, and this is accepting additional money to support the vaccine program.
So this money is specific to help outreach and ensure that those who are homebound out in our community of any age under the New York Connects program are able to get the vaccines at home. And so I have had discussion with Kathleen Cuddy and some others as far as how we can best go about that. And we're in the process of perhaps doing some kind of memorandum of understanding or something to come up next month. But we wanted to get this money in place and accepted this month. So we're ready to go.
I'll move HH4.
Nightingale second.
Okay, all in favor?
Aye.
Okay, great.
Aye.
All right, thank you. All right, Brenda, thank you very much.
Thank you.
Okay. Now we're going to talk about the HH5. We'll do the DSS resolutions. Okay, if you want to talk, yeah, come on up or have a seat up there, let them give us kind of an update or anything you want to talk about.
Sure. On the agenda, there's a few bullet point updates that we had come up with to talk about this month. One of the exciting updates is that the New York State's emergency rental program, the ERAP, that has been widely advertised in the county on social media, banners in the street, banner on the building, has opened. The portal opened on June 1st, and a few days ago, we had almost 400 applicants from Cayuga County that had submitted applications through the online portal. We believe the number will be quite a bit higher, still have another 3 days. They haven't reported out yet what our numbers are, so I think that's really exciting. Our community partners that we had contracted with to help assist the residents in filling out applications, helping them obtain a computer or computer device to actually get online and complete that application. They've been working hard to manage the flow of folks that had been eagerly awaiting the opening of the portal. They communicated with us that they've been really busy, that they've been helping answer questions on the phone, helping people out in the rural areas, going to them to help them complete applications. So I think our numbers show that we did a really nice job of providing that information, and we're doing the outreach and hitting the streets really to help folks where they need it. So continuing numbers, I'm hoping that we'll see.
At one point, I think Ray talked about that we're part of the Central New York allocation, a regional allocation. Any concern that, this money is getting used up? I mean, you haven't heard any.
You haven't heard that, so we think that we're going to get, hopefully soon, we'll get more information on how much money has actually come to the folks in our community, in our county. They haven't provided that yet. We've really just had numbers so far, but I think that's a pretty good number.
Yeah.
Some of the other counties that have been on some phone calls that we've had have had lower numbers. I think that hearing what they've had to say, I think that we're doing pretty well. We're
400, you said?
It was like 390, that was our last update.
That's great.
So they're continuing to book those appointments and go out to see people that need to answer questions, direct them to the right resources to answer their questions about submitting applications, fielding phone calls from landlords, and fielding phone calls from community providers that are trying to help get information out there. So very, very exciting.
Can I ask a question on that? Has anybody actually received their funding yet, or how quick is it for a turnaround on an application?
I don't know that anybody's received their funding yet. From my memory of the phone calls and the time frames, they have to work their way through the whole application. Everything has to be submitted. that is needed, the documentation. They talked about a 30-day turnaround time from application to money actually going out. So we're not there yet. So I would be surprised if money's going out yet.
And does it go directly to the landlord? Is that how it works?
Go directly to the landlord. That's it, yeah.
Okay.
So the department is continuing to work on our readiness for Family First that's coming in September of this year. We've been working on developing our some protocols that the state has asked us to implement. Blind removal protocol is one of them, where we're working to make sure that we're keeping our bias out of our decision making and when we're removing children, or considering removing children from families. That's something that we have work groups going on to help us like take a look at our procedures and our protocols when we're we've identified a family that has safety issues. The other one is kinship firewall that will help us to make sure that we have identified all of the family resources and family members that may want to be involved in helping care for a child that needs to be removed from their home. So again, this is a procedure, protocol put in place to make sure that we're doing everything we can to
The resources, family
yeah,
resources.
to identify family resource and not have to use traditional foster care when that's not necessary. The other thing that's happening around Family First readiness is we have to identify a qualified individual to take a look at children that are being placed in residential treatment centers. If they have that level of need to go to a residential treatment center, it's going to be different in the way that we are not able to just make that decision alone as a department. Someone that's this qualified individual who has a therapeutic background must examine the information on the child, do their own independent assessment of the child and their needs, and then make a determination that yes, indeed, this is the level of care that this child needs. So that will be done at different markers in the case, and we have to decide who we want to be this qualified individual. So we're taking a look at some of our options.
And that documentation goes to someone to review.
Yes, this is QI. The qualified individual will be the person that reviews the information and also does an independent assessment on the child.
And you have to have that, the assessment, and you have to share that. I mean, that's what we were talking about before the meeting opened, and, you know, the state and the feds are no longer paying for PINS placements in residential or detention. That's been over a year or more. September is the juvenile delinquent review, and all the hoops you have to go through, where there'll be no reimbursement for those expensive placements either. And this qualified individual, you have to have the assessment in hand and that you need, if you don't have that, you can't claim for reimbursement.
Correct. And the residentials are going to want to keep these children. You know, that it's just to make sure that the child has that level of need to have to stay at that level of care. So again, why it's so important to make sure that we have all those resources, family resources and supports for those resources in place and ready to go for September. You know, making sure that we have all the procedures in place and caseworkers trained to know how important this is. So the department continues to become the guardian of vulnerable individuals. We're continuing to see folks coming our way who have significant issues around being vulnerable, financial exploitation. We've had to become the guardian on some folks because of that. That's really, that continues to be a concern. Temporary assistance, the telephone waivers that we've had and have had in place for the pandemic timeframe continue and remain in effect, and makes things much easier for folks in the community to be able to receive their benefits and not have to worry about coming into the building and making their way here. If they're concerned about, you know, being vulnerable health-wise, so that the OGDA has continued those waivers.
And May's for a while, is your
Yeah,
sense?
yes, That is our sense, that that will continue to be something that's offered to folks. And I think that prior to the pandemic, it was really hard to imagine that that would transform in that way. But I think that having seen that happen and, hearing the feedback from folks around how much easier it makes it for them to actually obtain the benefits and work their way through all of the necessary steps to be able to have their eligibility determined has been one of the benefits, I think, to see that in action and to know that if that continues and they allow that to continue, it will be very helpful to folks.
You still have to get the documentation and all that. You just don't have to do it through a face-to-face.
Right, they don't have to drive here.
Right.
Don't have to bring paper in. There's an app that people can use to take a picture of their documentation and send it into the county. It's flagged as a Cayuga County document that comes right to the worker, so they don't have to drive it here or put it in the mail and have it, maybe sometimes things get lost. So much more great use of technology, I think, in a way that assists people in a bunch of different ways. So our emergency housing numbers continue to hover around 75. About 20 of those cases are family cases. That number is this time of the year, I think is a bit high. I think that speaks to just the housing issue with folks aren't leaving housing because of the not being evicted. It's hard for people to find housing. There's just not a lot out there right now. So those numbers continue to be around 75.
And it's still defaulting to hotels.
Yeah. Yeah, we had another hotel from Weedsport that wanted to kind of jump on board and take families if we need that. So that's good, continuing to look at those resources and try to meet the needs of the folks that are leaving the housing.
Can I ask a follow-up on that? Do those numbers include domestic violence cases?
No. Is that 75? No. And then we have been talking about what's going to happen in September when hopefully, children are back in school in a more traditional way. And, the cases that we've had and been dealing with this year, we're feeling like children that have had trouble this year with truancy are going to continue to struggle with kind of getting back in the door at school and feeling comfortable there and, attending. So we're thinking of ways that, we can get out to the schools to try to strategize and talk about services that are available and make sure the school knows that, what services are out there that, the department can help with and the county can help with, so that we can kind of get a good start in September with identifying those families and those children and giving them the support that they need to help the kids be successful. Honestly, we are thinking that we're going to have quite an uptick of cases where the school is concerned. They're seeing children again, hopefully in September, that they haven't seen in that way in quite a while. And we think that those children that have struggled are going to continue to struggle in school in September.
And these could come in as ed neglect petition or ed neglect cases that you really don't, PINS cases that you don't know really.
Right.
You certainly don't want to take them into foster care.
Right, we don't want to. So we want to make sure that they're getting the services that are available and that we're aware of that and that we're partnering together with the schools to try to help the families get what they need so that we can help these kids, be successful in school and attending the way that they need to. That was all I had for updates.
Okay. We can get, what I'm thinking, because the HH 5, 6, and 7, we can kind of group together because, and then I'll get a motion for the 3 of them because each of them it appears to be fulfilled by vacancies within the department.
Yes.
Fully, I'll move it as a bundle.
Okay,
Nightingale, second.
okay. All in favor?
Aye.
Hi.
Okay.
Aye.
Okay, great. Thank you,
Thank you.
Christine. Yep. We're down to 3 resolutions for mental health.
Resolutions first or update?
Whatever. Would you like to give us an update first? Or?
Sure.
All right.
So I sent you guys So it's good to see you all.
Yeah.
It's nice not being in a closet at home,
Oh, I was Gilbert.
because that's the only place that the internet works. And
Oh, I wondered where we were going with
That's
that.
what you were seeing every time you saw me, when you saw me. I think the thing that's really sort of, telling is, like, I've never come up here before and said, we were busy. We were getting killed over at the department. I mean, the level of need, the walk-ins, the crisis calls, the hospitalizations, the suicide attempts, the overdoses. It's pretty concerning. And I think that we want to do some planning around that. So I think we're gonna have some conversations about some thinking that we have. And I think in here it talks about wanting to make some enhancements to mobile crisis to be able to respond to overdoses as well as behavioral health crises. Also, open that up to the public so they can get some immediate help with a phone call and all of that. I think we're working on that. And our local plan that's due on 7/1, there's quite a bit of language around how we're going to, you learn this, this has taught us a lot, right? What happens when the social fabric comes apart a little bit, what happens when social determinants of health are sort of, impacted, and the typical sort of supports that people rely on to stay okay, what happens when those go away. So I think some of the investment that we're thinking about is about building up that sort of capacity in the community as well too. I don't think we're as strong there, as we should be. We're going to start the suicide prevention task force again. Elaine was part of that many years ago when I first came here. A bunch of really cool things happened that have been really key in the work, but I think we're going to have to do some more thinking and some more planning and some more strategizing around how we can do a better job of taking care of people, finding out who they are, giving them opportunities to reach out, and training people to sort of identify the at-risk folks. And it's just a really slippery kind of thing, but it's just like we're working, it's the same in the Department of Social Services. We're working like we have the tools, you know what I mean? We're working really hard, but we're really not making the impact that you would expect that we would. So that's a little kind of concerning as well too. So we'll step back and do some more thinking about that.
Okay, I have a question.
Sure.
Are you noticing with the overdoses, the suicidal ideation, et cetera, pockets of areas within the county or the city, or is it generalized?
So with the Healing Community Study, we do a thing called OD mapping. So you see this, I can get you this stuff. So you'll see that there are concentrations of overdoses, like, so Moravia has quite a bit. There's like 4 or 5 spots in Auburn. So we target stuff there, so that we do pop-up Narcan events there, because that folks there have seen or witnessed or know somebody who overdosed. So we get an awful lot of activity like that. We haven't mapped the suicide yet. The data on both of those is a little slippery, but better. I think we're getting better at getting it, but we're much more targeted now in some of those sort of interventions, which I think is helpful.
That epidemiologist you have.
Oh, yeah.
Healing Communities puts this map, the hotspot map together. It's pretty amazing information.
She works for Cornell, Corinna Noel. She does a really great. We've never had that before, like that someone who could could help us figure out how to gather it. There's that part, and then there's what do you do with it when you get it, because it doesn't always say what you think it says. And then so she's really good. That's been really, Healing Communities has really given us the some resources that really help us look at stuff. And that's some of the suicide stuff that we're getting is really from that work as well too, because we're getting those. So we talk about, and again, the community of providers and the people that are involved, it's just been phenomenal in terms of wanting to partner and figure out how to move forward and do it. Like the hospital's doing really good. I mean, everybody's been busy doing this other stuff, you know what I mean? So the fact that they can pull time out like that and make room for that is encouraging, because you need everybody for this thing. But there's Just this level of need with the kids that, like the kids that are presenting at the emergency room that are expressing suicidal ideation or attempts and stuff like that are kids and that we don't know, never have touched the behavioral health system before. And, you know, over the Memorial Day weekend, I think 3 or 4 kids showed up at the emergency room like that. And it's really hard to find those beds, and maybe the beds aren't always a thing, but just there's some areas that we have to strengthen up, I think, in our safety net. So that's
Just
kind of where
kids
we're
under
at.
stress, I mean.
Oh, the
that's what-
stress, sure. Stress is unbelievable. And I think like Christine talked about, you know, when September comes along, there's going to be a big, the level of anxiety, my guess would be with families and kids going back to school and teachers, you know, going back to all in-person learning. I mean, I think like we can take the masks off and we can, like I walk around and I think this is cool, right? I can see people again, but not all the kids that take the masks off are going to feel like that everything's all okay right now, because they've been trained and, you know, probably have become frightened about the potential for exposure and what all that means. So how that plays out with folks, with kids with their anxiety, truanting, you know, not going to school, because there's, I think that's going to be something we have to be mindful and thoughtful about. So we don't just get hit with it with on our back feet, but we have some sort of plans in place. So.
Right. We have so many students in every district who have the option to be full-time remote.
Right.
Who haven't been in a school building over a year.
I'm not sure. I don't even think that, I mean, some school districts aren't even offering remote learning anymore next year. So
Right.
that's, I think people have exercised that as a way to sort of manage stuff a little bit. So we'll see. We're going to be talking about that. We're coming up, talking to you guys some more about that. And that's kind of the report. I'm happy to answer any questions that anybody has, who's in the room or who's in the owl. Resolution.
The suicides and attempted suicides. I got a couple questions on this,
Sure.
I guess. So first of all, the integrity of the data, it sounds like we don't have like clear definitive sources yet where we can go to get a good picture of what's happening in the county around this stuff, do we? Or is it, where does the data come from mostly? Is it the,
So you get some from the coroner.
right?
Those would be on completed suicides, and those investigations, did someone leave a note? You know, are some overdoses suicides? So you don't, right? So there you go. So there's some slipperiness there. Was this an intentional overdose that was a suicide, or was it an accidental overdose? So you don't know. The ideation, you know, the people, so we know who shows up in the emergency room. Like we can get demographic data from them. We know those. We don't know what doesn't get reported, like in an aggregated way. So there's, you know, different clinicians will run across people who express ideation, and you don't know about that always. That doesn't come. So that's what's slippery about the data. It's housed in many places.
Does the hospital report to mental health? I mean, do you have communication between, you say 4 kids showed up because you know that?
So we usually find out from the hospital, right, the next day. They'll usually call and let more, you know, Maureen at the FAST team know. They usually let me know when they have kids in the ER, but not so much adults. So we talk to them, and they're very excited about. I think that's the next thing, is how are we going to sort of
Response.
be better at communicating that way and tracking it that way. So that's what that's part of what we're gonna do is figure out how to get a better sense of the data, particularly around, you know, attempts
Great.
or threats, because those are important to track those cases. And then it's going to be bolstering the sort of the way that we track those cases. Like, how's that going to happen? They need to be tracked, because you need to make sure that there's somebody, they can get lost too easy, a couple different ways. They could just not show up or not follow through anymore. I feel like we have an obligation to go check on them, see how they're doing, and which is a whole different sort of service delivery. I think we have a better handle on kids, obviously, because schools report and nursing, and there isn't a unit, there isn't an adolescent unit here. Adults is a little little slipperier.
And when you did the original suicide kind of task force that you had years ago and institutionalized the Columbia scale, all of those things you're gonna try to re-energize?
Well, they're still there.
Okay,
So, so we have a common language. So the hospital uses the Columbia Suicide Severity Risk Scale, it's an evidence-based tool. All of the clinics use it. The Auburn School District uses it. A couple other school districts use it. The providers all use it. The home-based services people use it. So that gives us the same language, because I don't understand what this person's at risk means, unless you can point to, this is the tool that we use. So now we know. So we have that came out of that. Mobile crisis came out of that. Couple other things. I think now I think they're pretty established. We'll check on them to make sure that they're still being used, but we're pretty confident they are. It's really more about, I guess, so we're gonna get some consultation from Office of Mental Health too. They're gonna give us a person that's gonna help us with this. They have folks who do this. And I think it's really more about what's this net look like that here's the net that we have. This is what we do. How can this become more?
improved upon.
Exactly. How can we improve upon it? What do we need? What kind of tracking? All that sort of stuff. I feel like we can get there. I feel like everybody's, again, like I said, the partners, the people, there isn't anybody that's not interested in doing this work. So, any questions?
Yeah, and then I guess my second question was, and I know that the schools are involved and everything, but have you seen the spike or the increase in the numbers? Have you seen the schools changing their response or their education around any of this?
I think we have to see. I think all the school districts are all sort of different.
Yeah.
That, they've got different resources, some are kind of resource rich and some aren't. And I don't think when we did it the first time, that we really got all of the school districts sort of buy-in on that. I mean, Auburn did a really nice job of committing time to draft policies, like what you do when one happens, that sort of stuff, because it's different than what you think you should do. You don't want to encourage clusters and stuff like that. So I think we want to do a better job of, and I think now the schools probably would be, I wouldn't say more agreeable, because I would say that they weren't agreeable before. I think that when we ask, I think they're going to be like, yeah, this is a problem for us. Let's see what we can do together. So I think we want to get everybody in the district, all of those partners to be part of this.
Madam Chairman,
Yes, Tim.
Ray, during this pandemic, the city council has now indicated that they think that maybe having their own ambulance system might be better than having a partnership with the TLC. If we learned anything from the pandemic in regards to maybe having different partners or different delivery systems that might be more effective than what we presently have?
I think, yeah, yes, in a way that's yes. I think that we've realized that we have that. So I guess on a couple of levels, one, services need to be delivered in a different way. So if there's a provider that isn't able to adapt that way, then I think that we're going to find one who will, right? Because it is different. It's not the same business as usual. Things have changed. I also think that if we're looking for something that's different than what we do now, there may be different providers for that as well. So they may have a competence. Some provider may have a certain competency that we may need. So I think that the lesson for us is we want our partners and the people who we pay to react and adapt in real time to the challenges that are in front of them. And I think we've sort of got a sense of who can do that and who can't to some degree.
Well, the county several years ago, we got out of the nursing home business, and I think we got out of the nursing home business just at the right time because the reimbursement rates were going down, and thank God we weren't in the business when the COVID hit, so that all of a sudden we had a lot of liability claims or anything against us. Is there any other partnership that we could do mental health with, like with the hospital or something that maybe might be, public-private partnership with the hospital? Would that make any sense for a better business model?
So I think there's some opportunity there, like we've talked in the past before, obviously this all got interrupted. Talked about there's value in sharing psychiatry, like at that level, like if we're starting to have discussions, you remember this, where our
Contract
doctors, our doctors would staff the behavioral health unit and would staff the emergency room for evaluation purposes, because then what you get is a pretty seamless, so the hospital would be able to save money
Contract with mental health.
contracting with us. And then the person who showed up at the emergency room and saw a psychiatrist, or who was on the unit and saw a psychiatrist, when they were discharged, would see the same psychiatrist. So you wouldn't get, like, just for that example, you wouldn't get med changes for no reason. So somebody was on the unit and they come out of the unit on a bunch of new medications that may or may not be helpful, or they may be contraindicated with other stuff, and then you gotta spend time titrating them off, which isn't really treatment, that's medication management. And so there are opportunities out there, and that's just one example. So I think we wanna hopefully explore all of that again. I think those conversations will be a little bit easier to have, because we all know we need friends now. We can't do it all on our own anymore, for real. So
Well,
I think,
that's what I'm saying, is that, we don't want to grow government anymore, do we? I think the private sector probably does a better job than we do, but.
my government does a pretty good job, I feel.
Yeah, I know that, but I'm just, well, anyways, I just want to make sure we have the best business model for the client
Absolutely.
and for the taxpayer.
Right. Any other questions for Ray?
Just one follow-up question. Are you working with, like, outside of the hospital? Are you providers in the community, general practitioners to,
What they care?
well, to assess some baseline mental health assessment of their patients as part of the physical care that they're getting?
So we've invited, there's a thing called Project Reach, which is sort of, the way that I understand it is, for our purposes, the way that we're going to use it is, we want to engage primary care practices, also OBGYNs. We're looking to engage OBGYNs around, opioid use disorder, because we have a lot of pregnant women who are still using, and they're reluctant to come into treatment, and the OBGYNs might not know how to do that. So we're going to try to engage them. We're trying to engage on a regional level primary care doctors and OBGYNs on medication assisted treatment, because that buprenorphine training that's been waived, so we can get some. So that's happening on a regional level. Locally, we're looking to engage pediatricians to have a comfort level with prescribing low dose psych meds, so that we can discharge those kids from county mental health, build competency in the primary care practice to treat kids, provide telehealth consultation to the physician practice, so that if somebody, they get that sort of support, and then the person needs to come back to the clinic, they can. So that's started. Maureen's doing that. Dr. Pratt is the guy who's going to talk to them, and we're going to do it on the adult side as well too, because like we're part of our one of the ways to manage 400 patient caseloads per prescriber is, can we move some of these people to their primary care doctor on like low dose stable medications to free up the spot in the clinic for someone that we can stabilize and move again, or somebody that we have to keep. So that work is happening.
That's great.
It'll increase the capacity you have within.
Oh, yeah. Plus also increase the capacity of the medical community to treat people with that just don't, because people talk to their primary care doctor differently. Like,
Yeah.
my brother always said, you never lie to your doctor or to your lawyer. And I think people have those conversations that they may not have with other people. So
Project Reach is a statewide initiative.
I don't know if it's statewide or if it's a federal thing. I can ask Maureen, but it's pretty established. And I think we're looking for a champion. So Dr. Anwar, right? So he's a pediatrician in town. I used to be on the Caregiver Center board before I came to work here. He was the medical director at the Caregiver Center, and he always talked about wanting to have that kind of relationship. And he actually, there's organizations that primary care and obviously pediatricians can contract with, because I know he did, where he gets some consultation from a psychiatrist. It was done probably telephone or telehealth back then to help him, because he sees a lot of kids with anxiety, attention deficit disorder. They don't need to.
Being mental health.
No, I
Right,
don't,
you can
I mean, they may,
manage,
but not
right.
usually. I think they can be handled. They get really nervous. There's a lot of reluctance in that system to write psych meds because it's a specialty, but we think we can get some partners to join.
Once you stabilize them, it makes.
Then they're off to the races. And then if something happens where there's an issue, that you're able to get on the phone and set up a telehealth visit with the child psychiatrist, because we have one, and then that, I think that doctor to doctor talk, that makes them more comfortable than like a doctor to me talk.
Mhm.
So, yeah, we got some cool things going on.
Okay. Any other questions? If not, we can get to the resolutions. I'd like to get a motion to put HH8 and HH9, group them together and have you discuss them, and then I can move them both. I can get a motion for both of them, but so if you want to talk about HH8
So,
and 9.
I mean, I don't know, the numbers, but the ones of state aid, like the state aid gets adjusted throughout the year. So there's a resolution to accommodate the adjustment of the state aid. And the other one is we got, so we were a SAMHSA system of care county. We have another SAMHSA grant out there. Hopefully we'll hear in a little while whether or not we get that. But the OMH, New York State Office of Mental Health has a SAMHSA grant. So we ended up getting a 25,000.
Yeah, what is
25.
that for?
They were going to show me the budget
Oh.
today, but I had to go sign some checks
Small
here.
thing.
So I'll let you know. I think what we're gonna do is, so some of it is to pay stipends to youth peers, right? To get more youth peer involvement, because it's a Medicaid billable services, so they don't have any free time. I think it's to purchase some of Dr. Pratz's time from the clinic to be able to do this Project Reach thing, to work with the pediatricians. And there was one other thing, I can let you know, though. I didn't get a chance to, Maureen and Liz put it together. I just didn't get a chance to look at it.
So HH8 is to make some adjustments in your state aid.
Yep.
Move some money in the state aid for 2021, and this is to accept $25,000 of SAMHSA money.
And then when we contract, we'll be back with the contracts. I don't think it says I can contract with them. So we'll be back with that.
Okay.
Like, yeah, movement.
Second? Okay, all in favor? Okay, and then HH10, Ray, is your request to create and fill one full-time social worker in community mental health, and take the funding from a funded but unfilled home health care manager based on the needs that you have for social work services.
In the 2021 budget, we added a therapist and a care manager. We hired the therapist, and the care manager is, we were starting to recruit for that. And I need another therapist. I don't need another care manager. So we're just looking to swap the positions, eliminate the one and create the other one. The therapists make twice what we pay them, and that's the help I need right now. It's really what it's.
You'll stay with the same number of full-time equivalents,
Right.
but you're just not going to fill this because you're unfunding it and you want to create and fill the social work.
Right, I need help in the clinic. Their case loads
Reimbursable.
Right.
are huge.
I mean, both are reimbursable.
All of them, yeah, they both earn twice what they cost salary.
And the care manager works for health homes,
Yep, health home care manager.
but you have enough capacity to meet that need now.
Well, there's plenty of health home providers in the county, so we typically take the really seriously and persistently mentally.
You're not the only game in
We're
town
not the
for
only
care
game in town
manager.
for care management, right?
Okay.
But we're the only game in town for an open access clinic.
Can I get a motion for HH10?
Like, yeah, move it.
Okay. Yeah, I mean, basically, that's the conversation that Ray and I had, that at this point, in order to meet the real critical need, you'd rather take up this position. And
Yep.
okay. Any, okay, all in favor?
Aye.
Okay.
Aye.
Mark,
Yep, I'm good.
all right.
Thank you.
Great.
Yes.
Good.
Yes, we're good.
A motion to adjourn.
Second.
Okay.
Well, these guys are
Nightingale
all
motion
under
to
Dean today.
adjourn, her second. All right, everybody, thank you.
Thank you.
Right.